The reason why out of all the cardiovascular topics, I picked speaking about venous disease, in particular, the layman's terms, varicose veins, is because it's probably the most prominent vascular disease in not only our country, but probably in the world today. If you look at the chart up there and you look at where it shows you venous disease and its etiology and prevalence, it far outweighs other cardiovascular diseases, heart attack, stroke, and other arterial risk factors by more than 20 to 1. It's really the most prevalent of cardiovascular disease we have today. So I'm going to try and focus on that a little bit tonight. A lot of people wonder who has varicose veins, who gets varicose veins, why do we get them? It really happens at any age. We see a lot of patients that are under 20. People think that, oh, it's a disease of the elderly. That's really not true whatsoever. It's very hereditary driven. Pregnancies have a lot to do with it. Hormonal things have a lot to do with it. And certainly age has a lot to do with it too. If you go back to that other slide, you can see as the incidence of the people age, people over 60 years old, over 70% of people over 60 years old have some form of venous disease. In their 20s, it's less, but it's certainly still very prevalent. 8% of all 20-year-olds in this country is an inordinate amount of people to take care of. And so it's very prevalent at every age. Venous disease also, besides being prevalent, comes in many forms. Although we're very familiar with the fact that it's a spider vein or a varicose vein, I'd rather use the word venous insufficiency or venous reflux disease because venous disease takes many forms. Whether it's my legs are swollen all the time, whether I have skin changes, whether I even have a venous ulceration, as well as the spider veins and varicosities. It has many forms, and I'm going to explain some of those to you and why we get them. As far as other risk factors, pregnancy is very high because of the hormonal imbalances that produces, because the hormones that women are exposed to on a monthly basis and when they're pregnant have the same effect on the uterus, which is made of the same type of smooth muscle as you have in your veins. And it's made to dilate and receive the fetus, so that happens on a monthly basis to your veins also. It's why some people feel it on a monthly or cyclical basis because of the progesterone and estrogen hormonal changes cause venodilatation once a month, and some people around their menses or their periods are going to be a little bit more symptomatic. And in pregnancy, it kind of goes without saying. The other thing that we see a lot of, and there's another risk factor, is we see a lot of our patients are school teachers, nurses, pharmacists, people who stand on their feet a lot. That's another risk factor. If you find that you either stand or sit a lot, anytime your feet are below your heart, you're going to be a little bit more propensity for having venous insufficiency. Well, let's just start off. I want to focus on vein disease itself, but I'm going to start off with what everybody's kind of used to seeing, and it's with varicose veins. And what is a varicose vein? If you look at the strict definition of a varicose vein, it really is any vein that dilates. And this is one of the cases where actually size doesn't matter. It can be a very small vein, where we call it a spider vein or a telangiectasia, or it can be a very large vein. The classic definition of varicose vein, however, is any dilated vein. So we can really even refer to spider veins as varicose veins if we want to. So they come in many different forms. And as you can see up there on your left, or just a classic spider vein, something in the middle, what we would call a reticular or a blue vein, and to the right are large varicosities. Why does this happen? Our bodies, from way back when, we were really supposed to be walking on all fours. And as we stood up, and a lot of the blood flow and blood volume in our bodies stood up and pushed down at our lower extremities, we have little valves that open and close that are supposed to stay closed, stop the blood from running down your leg. With time, with standing, with hormones, these little valves, and you can see on the right, start to dilate open. Well, what happens with that is a lot of fluid starts getting pushed down your leg. And so now you have pressure down your leg, you feel swelling in your leg, fluids pushed out into your tissue, and that's what causes the swelling. That's what causes the varicose veins to dilate, and that's what causes a lot of symptoms of night pain, cramps, aches, etc., which I'll get into down the road. But it really comes from the varicose vein valves becoming what we refer to in lay terms as leaky, for lack of a better term. As far as the anatomy, people talk about really two main veins in your lower extremities. They're both variations of your saphenous vein. The one in the front of your leg is called your greater saphenous vein. It runs all the way from your groin to your ankle. And you can get symptoms, pain, or varicosities anywhere along your entire groin to your ankle level, most commonly at the calf level. The back of your calf, if you have pain, swelling, or tenderness or varicosities, the smaller saphenous vein runs from the back of your ankle into the back of your knee. And that also can become varicose or dilated or aneurysmal as well. And those are the two main veins that really become aneurysmal or varicose. Spider veins do come in all shapes and sizes. You can see some women come in with in their 19, 20-year-old kids may have one little spider vein, or you could have small clusters, or you could have massive amounts of spider veins. I'll tell you some of the significance about these down the road. The younger people are more concerned about the cosmetic effects of these. However, we find out that these spider veins have a deeper root with some other abnormalities, and can be the symptom, or can be the demonstration of more underlying venous disease. So even though they look like they're cosmetic, they can indicate a more deeper venous problem. The varicose vein, again, also come in different forms, or you can get a combination where you see on the left, that's basically bulging in your greater saphenous vein. In the middle, it's more of a variation of a worse saphenous vein. And on the right, it's really much of a combination of smaller saphenous veins and big saphenous veins. Things I want you to realize, though, too, is venous insufficiency or reflux comes in a lot of different shapes and sizes. My legs ache at night. My legs hurt during the day. When I get up, my legs start to feel heavy as the day goes on. I have progressive swelling as the day goes on. My ankles aren't swollen in the morning, but they're swollen in the nighttime. Very classic of that. When I go to bed at night, I have restless leg syndrome. My legs are achy or crampy at night. All of these are variations of venous insufficiency and pressure in your legs as the day goes on. And it all comes from once your feet go below your heart level, that pressure starts building through those leaky valves I was speaking about. This is a woman who actually came into our office for a variation that obviously you can see she has edema, she has a spider vein, she has the varicose veins, but you see in her upper thigh, one of the earlier and more common complications of venous insufficiency is as the blood sits in these varicose veins, it can thrombose and clot. And when people say, I've had a blood clot in my leg, or I have phlebitis, or somebody's referred to as you have phlebitis, you can see in this patient, this is a couple-week old, but she has a big, large, tender mass in her thigh. And that's one of the earlier and less severe, but getting into the complication range of these varicose veins, and why they really shouldn't be left alone, and demonstrating why they're not really a cosmetic problem as much as they should be really treated. Spider veins come in many variations, and I'll talk to you about those down the road. These are all pictures of our patients with all kinds of combinations of varicoses, all that we treated, and I'll show you those down the road. I think really more of a take-home message in this whole thing, though, is the misconception that varicose veins is a cosmetic problem. Your friend sees it and says, well, don't worry about it, you just have varicose veins. Worse, your doctor sees it and says, you know, if it's not bothering you, don't worry about it. The biggest misconception is that it's cosmetic, but the fact of the matter is you can get blood clots in these veins. They can go to your lung, and people say, I had a blood clot go to my lung, and it can actually kill you. So you have ulcerations, you have clots in your legs, you can even have an embolus go to your lung and kill you. So I'd like to take that, it's a cosmetic problem out of the nomenclature, because it's a very serious medical condition. Again, that should be addressed and treated. And your family doctors, and that's why I like working in the St. Joe system, they're all very knowledgeable about venous disease, and they'll refer them immediately where other doctors may not be as knowledgeable, and they won't do that. And the next time I see somebody, they'll be in the emergency room with a blood clot in their lung that we've got to take care of. Now that you've had the signs and the symptoms, how do we progress from there? You've come into the office, or you think you have any one of these symptoms. How do we make the diagnosis? Well, as any doctor does, the initial diagnosis is made with a good history and physical examination, and we go through all that. The one thing that I notice, again, when you look through the literature for physicians, is this. Most doctors, when you're in their offices, now, not all of them, certainly nobody on the St. Joseph staff, when you go through your physical exam, see how many people have their shoes and socks taken off, okay? It comes out to about 15%, which is about 1 out of every 10. How do you make a diagnosis of peripheral arterial disease, of venous insufficiency, or of any lower extremity disease without taking their shoes and socks off? In this day and age of cost containment, accountability, whatever kind of managed healthcare you're in, physicians are so time constrained that getting shoes and socks off and things really has become a thing of the past. And so that's another problem. If your doc's not taking your shoes and socks off, they're not really getting a good look. They're not sitting there and spending the time asking about some of these questions. Restless leg syndrome, who knew that would have anything to do with venous insufficiency? your shoes being off? Do you have good pulses? Is it a PAD or arterial problem, or do you have, or is it a venous problem? They've got to be looked at. And this one study I quote here, only 15% of exit polls of patients coming out of a doctor's office even had their shoes and socks taken off. And then on the side, only 15% of patients had the doctor listen to their neck for noises that you could prevent stroke and things like that. So medicine's really become very specialized now, and doctors are focused on your problem and your problem only. So if you point out the fact that you've got a swollen leg or you've got varicose veins, you need to show it to your doc. You need to have him take a look at it, and he needs to take it seriously. Well, once we've gone through the physical exam, we've looked at your legs, we've done some things, really the next step for us to decide what is exactly wrong with you, and for us to tell you, is there something we can actually offer you? I mean, it's great for me to tell you you have a disease. It's great for me to tell you we found something, but what are we going to be able to do about it? And is there anything we can do about it? I mean, that's what people want to know, not you have some weird disease that we can't do anything about, have a nice day. The next step, and in our vascular lab in our office and at St. Joseph's, we use ultrasound machines. And these ultrasound machines are able to actually look inside of your veins and not only tell you do you have blood clots or not, but are those little valves we've been talking about actually opening and closing correctly. And we can actually look at those valves and tell you if they're opening or if they're closing. If they're staying stuck open, that's a sign that you have venous insufficiency and valvular incompetency reflux.